Hi everyone. And this is a VENTI Pre-Event live stream event. I'm Yuji Okuno, and we are exciting to welcome you. And we are now going to do the 3 cases of MSK embolization from here. And now more than 100 people audience now online. And we have Gerard Goh as moderator and 4 worldwide international commentators. So Dr. Gerard, please, Dr. Goh, please introduce our meeting and this event and our commentator.
Well, thank you very much, Yuji, and welcome everyone to the first VENTI live cases stream. We're very fortunate to have Dr. Okuno perform 3 cases today, and I'm joined by 4 very distinguished commentators from around the world. First, we have Dr. Marcus Katoh, who is the Chief of Interventional Radiology at the Helios Klinikum Krefeld in Germany. We're also joined by Dr. Keng Wei Liang, who works at the Chung-Shan Medical University Hospital in Taiwan. Dr. Sang-Woo Park from the Konkuk Limb Vascular Center in Konkuk University Medical Center in Korea. And also Dr. Bo Wang, who works in the National Cheng Kung University Hospital in Taiwan. So we're very fortunate to have these excellent commentators join us tonight who will be giving some commentary of the cases as we go through them. So let me walk you through today's schedule. As you can see on the screen, you can see the outline of the webinar here today. There are going to be 3 cases performed by Dr. Okuno. The first is an Achilles tendinopathy case, followed by a tennis elbow case, and these cases will take about 25 minutes each. The third procedure will be a knee osteoarthritis case, and eventually we'll have some time for a review where we will have some comments made by Dr. Okuno as well as the commentators. And we'll plan to conclude the webinar in about an hour and 50 minutes. So there's an opportunity to ask questions, and let me explain how to ask questions during the live cases. To ask a question, please click on the question and answer or Q&A icon on the Zoom control panel. There, you'll be able to type your question and please press send. And please note that we won't be using the raise hand feature. So if you do have a question, do put it in the Q&A function. And we'll be accepting questions anytime throughout the demonstration. So please type any questions that you may be curious to ask about. And we'll either address the questions during the review time or respond to directly within the Q&A section. At the end of the webinar, there'll be a very brief survey, and we would please ask that you would kindly fill out this survey because this will give us feedback on today's session and allow us to improve this course for future iterations. So without further ado, Yuji, would you be ready to start the first case?
Yes. So first I will introduce the case. So if you Gerard or the commentator, please if you have a question, please interrupt me. It's okay. And the first case is a chronic Achilles tendinopathy and 30 years old and 6 months history of left mid portion Achilles tendinopathy. Mid portion and insertion, both mid portion and insertion. And he played soccer, football, and in the recreational level. And pain NRS is 8 out of 10. And Visa A is a Achilles tendon specific score was 36. 36 means severe because 0 is most severe and 100 is pain-free. Good. And less than 50 means severe symptoms. So we can say that this is a severe symptom. And this is a baseline ultrasound imaging. And the left is the affected side and right is the healthy side. As you can see, the affected side, mid portion have increased color Doppler signal. So this is a sickness increase and the color Doppler signal increase. There is a ultrasound grading scale of neovascularity. we call it OBAG neovascularity score, that from 0 to 4, and 4 means more than 3 vessels. So we can see the more than 3 vessels, so we can say that this is over grade 4. The over grade 4 means a good indication for the embolization treatment. And if you have any question or comment, you can interrupt me. And he also have, sorry, ごめん、次行って。Yes. And he also have insertional tendinopathy. So Achilles tendinopathy divided into 2 groups: mid portion tendinopathy and insertion tendinopathy. And he has both. So two areas: mid portion and insertion tendinopathy. So we will treat both. Let's see. And
okay, Dr. Okuno.
Yes.
Yeah. Can I have a question?
Yes.
Yes, great case. I think the please let us know the patient, what kind of treatment the patient get before visiting your lab.
Yes, thank you so much. Yeah, I think that the current slide is the previous treatment I described.
Oh, yeah, great, yeah.
Yeah, so he already received 3 months of physical therapy and 3 times PRP, 3 times PRP injection. So, and it didn't work. So he came to us through the website. So that is a brief history. It's okay? Okay.
Yeah.
Yeah.
Okay.
Thank you. And our previous data, and now we are preparing, submitting the Achilles tendon retrospective analysis of 2 years analysis data of 82 patients using imipenem. This is under review in the CVIR, but our data shows that the clinical success rate in recreational level patients is around 87%. The clinical success in this study, clinical success means NRS decreased more than 50% in 1 year at the 1 year post. And patients with OBAG grade 4 signal on ultrasound was 100% success rate in our case series of these 82 cases. So we can expect the good results from him because he has a grade 4 OBAG, grade 4 OBAG, and also recreational level. Competition level patients have inferior results, competition level. The top athlete has a good results, but the middle age, 50s, 40s, 50s, and he or she plays a competition level. It's sometimes we cannot have good results in some cases, but recreational level, it's more easy to the restrict of activity. Okay, okay. And this data also shows that greater angiographic hypervascularity correlated with a higher clinical success rate. And the other thing is the super selective embolization showed better outcomes. So sometimes the Achilles tendon's feeding branch is very small. So sometimes we cannot cannulate the microcatheter into the small branch. But compared to the method from the imipenem shower from the main trunk or the super selective, to the insert the microcatheter to the small branch and do the super selective embolization. The super selective embolization shows a higher success rate. Okay. And this is planned procedure detail. So ipsilateral antegrade femoral puncture and 3 French angiographic catheter. And I will show you later, but 1.7 microcatheter, length 125 centimeter with single curve, and target artery is posterior tibial and the peroneal artery. And we use imipenem, and we want to do as super selective as possible. Let's see. Do you have any question or comment? Okay, this is the final slide.
There was a question asked by one of the audience members, Dr. Liang. Perhaps you'd like to answer this. So when you say recreational level, what does that sort of mean?
Yeah, thank you. So recreational level means that they do not participate to the competition opportunity like nothing, like yeah. So
sort of like I
like
guess
for hobby, that
for a hobby, yes,
but
yes.
doing
So not professional.
not professional, not professional.
Yes.
Yeah, yes. Okay. And any other?
Yuji, maybe one other question. You said plus or minus next year. So do you have any strategies for this?
Yeah. So I think the only imipenem is still good, and if the brush is refractory to the imipenem injection, so usually we do this two round. First round we see the angiography and find the neovessels and infuse imipenem. And after that, we go to the other side and check the angiography again and get back to the first target and do the angiography again. And if we can see the, we cannot, so if the hypervascularity remains a lot, maybe we can add the other type of embolic but we are not sure this combined strategy can have higher results or not. We are not sure about that, but maybe we will try to use or not.
Okay.
Yeah, it depends on the patient's response, vascularity response. Okay. And this is the angiographic illust of the Achilles tendon mid portion or incision. Yes, this one. Okay, so let's start the procedure.
Okay, thank you very much. We'll leave Yuji to get started with the procedure. So question to the panelists. Achilles tendinopathy, that's typically a very difficult procedure to treat. And so is there any reasons why you think Achilles tendinopathy, particularly patients fail conservative management? Would any of the panel like to take the question? Thank you.
Maybe you could repeat your question, Gerard.
Yes, the question is Achilles tendinopathy can be very difficult to treat with conservative treatment sometimes. Do you have any thoughts of why it's a very difficult condition to treat with just medication and physiotherapy, and why some of these patients fail conservative management?
I mean, there are many theories about the tendinopathy, and as far as I know, I mean, the neovascularity is a key point in this disease. And I think all the conservative therapies we have actually cannot target this kind of neovascularization. And all the stuff is doing by operation, for example, they are very harsh. So they open up and they try to separate the paratendon from basically from the tendon to disrupt these kind of vascularity. And so I think this cannot be done with only conservative therapies. And I think this is the reason why it fails mostly.
And I know the Achilles tendinopathy tend to have a very common and frequent recurrence after the conservative management because the patient movement is very frequent and too big. So even though patient has some degree of the pain, so the the many trial of the injection or the medication sometimes didn't work. So I think that it could be very good indication for the TAME. Rather than the osteoarthritis or any other the frozen shoulder.
Yeah, certainly we know that the Achilles tendon particularly is a very big weight-bearing structure because it takes the whole
correct.
body weight on every
Correct,
footstep you do. And so I think that's one of the reasons why there's a high rate of recurrence, because it's this continuous, repetitive, strain-like motion on the ligament. And so once you treat the neurovascularity, if it's very difficult for a person to stop walking or hobbyists to stop playing sport.
Yeah,
and so you
correct.
get that repetitive
Correct.
load on the ligament.
Okay, so now I have prepared, and now I think we can start the procedure. So I think our staff member will change the screen. 藤原さん、共有して。Maybe I think now you cannot see my angiography now. You cannot. Okay. Okay. I think from now you can see.
Yes, we can see that,
Can you
Yuji.
see?
Thank you very
Yeah,
much.
Okay. Thank you. Thank you. So now I am using a Asahi 1.7 French microcatheter, and I think you can see the. I will move a little bit slowly and go to the PTA. And I use the 3 French angiocatheter. I think you can see now. Okay, so go to the.
Is this a 3F mongoose?
Yeah, so the shape of the angiocatheter is Jadkin's right, 2.5. And the length is 65 centimeter.
Okay, Dr. Okuno, you didn't use the guide wire or micro wire?
I usually do not use a guide wire for the selecting the basic branch, but without wire, like this. Cool.
I think your microcatheter act as a micro wire or guide wire.
Yes. I use a microcatheter like as my guide wire. Okay. So now we are reaching to the point. Okay, so we can see the PTA. So I will first go to PTA, just a moment.
It could be the posterior tibial artery.
Yes, posterior tibial artery. And insert the microcatheter into the peripheral side. Can you see? Can you see the movement? Okay. Okay, now we are reaching to the affected area. Just a moment. Okay, so I will change to the lateral view. I think now you can see the 2 marks. Okay, so I will do the first angio from the PTA.
声は大丈夫です。はい。Okay, from here, we cannot see the brush so lot. We can see the brush at ankle joint level. I think that is a synovitis finding. So can you see my photo? Okay, maybe you can see my. Can you see my pointer?
Yes, we can see the angio run there and your
Yeah.
pointer.
Yeah, this area having a small brush. This is not a brush of Achilles tendinopathy. This is the brush of synovitis. I think he played football well, so he also have synovitis in the ankle joint. We can treat here later. This is because this is not a first target, but I will come back here later. But so we know this case is the main target is peroneal artery, not the PTA. So I will go back and select the peroneal artery. From our data, 30% patients have only have a brush from PTA, and 30 has only from peroneal, and the remaining 30 or 40 have both have brush from both PTA and peroneal. But I think these patients have peroneal artery is number one target. I will change the data so that you can see the catheter tip well. Now you can see the catheter tip, and I inserted the microcatheter to the peripheral area of peroneal. Now I'm coming from the peroneal artery. Okay, so it's just a moment. This microcatheter slide. ちょっと見づらい。Okay. So now we will do the angiography from the peroneal artery. Okay, so from PTA, you can see the obvious brush on the.
Yes, right there. Yeah.
Yes, Achilles tendon. Yeah. Okay. And in insertional tendinopathy, there is no obvious brush. Okay, so I think I think we can do the super selective angiography. Just a moment. This is not. So this microcatheter have single arm, so and having a good torqueability, so we can sometimes use such curve to select the branch. Okay, from here I will do the angiography again.
You can see that blush coming just particularly around the insertional portion of the Achilles, can't you?
Yes, yes. So we can see the both. This is the main region of the mid portion, and this area is the insertional tendinopathy area. Okay.
So Dr. Okuno, I think the end is to more than two small branches could be related to the brush right there.
Mm.
Yeah, so I think you need to super select the small branch. So each small branch is the respectively, okay?
Yeah.
Mm.
So I think these two branches connecting well. So
Mhm.
so maybe we don't need to do the all to select all the cells or not. But I try to first go to this branch by using. I think I need a guide wire, micro guide wire.
Yuji, can the patient feel something? So did he experience
Thank
any
you.
pain?
You asked. Yes. So now we are using the. Now we are using visible is equal osmolarity. So patients now do not feel anything. Patients now does not feel anything because we use the visible. Visible is equal osmolarity. So right. So he doesn't feel anything now. Okay.
So one of the beauties about this microcatheter is that it's got such a small and atraumatic tip that we could see Dr. Okuno using that almost like a guide wire, as like Dr. Wang said. It's so atraumatic, but yet it still retains that ability to talk.
Maybe we call it wireless technique. Yeah, just use the micro catheter as the wire. Yeah, to guide it. We call it wireless. Yeah.
Yeah, this is a wireless technique. Wireless technique requires a shorter time or procedure time. Okay.
I've had once somebody call it the Wi-Fi technique.
Wi-Fi. Yeah, I know. Wi-Fi. Why they call Wi-Fi? What mean Wi-Fi?
Because you know how you have internet Wi-Fi, it is wireless.
Okay,
Therefore,
okay.
it's called the Wi-Fi
understand.
technique.
Okay, I understand. Okay, so now I inserted the microcatheter to the final target branch. How do you think? If I do the super selective, we can see the more vessels compared to the main.
Yeah.
Yeah.
It
So
could
now-
be culprit lesion, culprit artery.
Yeah. And we can also see the vein, early venous drainage vein.
I think it's a good position.
Yes, I think here is a good position. Yeah, so I'm now flushing by using saline and I mix with the imipenem here. I think the imipenem is the same in every country, but if I visit to some country, something sometimes not same in every country. Just
So Dr. Okuno,
yeah.
So what about the next PRF or the KIPJA, instead of the imipenem?
Yeah.
As you mentioned, the many countries doesn't apply the imipenem as an embolic material. Same procedure. So the same in Korea and as well as Japan.
Yes, yes.
Yeah,
So,
so yeah, yeah.
yeah. So we have to find the alternative to imipenem. So the Achilles and NextPF works well. And for Achilles, we can use the Achilles or NextPF from here. So I think these two embolic is also good. And now we have other option like Lipido or Sakurabis, or these are relatively a new. The Sakurabis is a new material, but I think this material can use from here too. I think.
Sorry, I lost your last mention about the embolic material.
Yeah, Sakura bead. Do you know?
I don't know.
It's from Ireland company.
Aha.
And the temporary embolic material. Yeah. So I put the 0.5 cc of imipenem now, and I think the patient feels evoked pain from here. なんか今感じます。なんか、アキレス腱かゆい。そうですね。He now feels itching. Feels itching is a good for the. So we know that the patient feels evoked pain. And we also can see that the branch to the insertional tendon is also covered from here through the anastomosis.
And Dr. Okuno, one of the questions the audience has asked is that do you ever consider using a vasodilator before injecting the embolic agent?
So far, I haven't tried that. I know that this situation is like a spasm, so maybe that can affect the clinical results better or not. I'm not sure. I think the Dr. Liang or Dr. Bo are writing a paper about that. How do you think?
Yeah, we just published an article about TAME with intra-articular nitroglycerin use on the MDPI on live. Yeah, but we use it only we meet the vasospasm. We don't, or maybe on the foot or on the ankle area when we found the vasospasm or the flow is too slow, we will inject some nitroglycerin, and it is about, yeah, you can find the article, search Dr. Bao or Dr. Liang, yeah. But we didn't compare if we routinely give nitroglycerin, even we didn't meet spasm, if it come better or not, because I am worried about the muscular branch and the cutaneous branch also dilated at the same time in the normal vessel, not only the abnormal angiogenesis. So I didn't do it routinely in my article and in my routine practice, only when I meet vasospasm. Maybe will be better. I'm not sure. Yeah.
Okay, so Dr. Katoh, do you use nitro during your procedure?
Actually, we rarely expect a spasm, so which is actually surprising. But at least in our institution, it's a rarity, absolutely, to use nitro, even in younger patients and even in female patients. So we encounter rarely vasospasm.
Yes. Because actually the below the knee, the small artery can easily make a spasm. So sometimes maybe it's helpful, but so far we haven't tested. We just wait if the artery makes spasm. Okay, so now I infuse 0.5 2 times, a total 1.0 ml of imipenem. So I will do the follow-up angio from here. So it seems like spasm. So we can wait but we can see that the brush is now decreased. So this is first round. So I will go back to PTA and treat the synovitis and come back here later. So I will go to the PTA. So we usually do the second round. It's important for the tendinopathy. Some patients.
I'm sorry, Yuji. A question for yourself or the panelists. Quite a few of the audience members are asking, what dose of imipenem do you use and how do you mix it?
Okay. So we use imipenem. We use imipenem 0.5 gram imipenem, 1 vial, mixed with 10 cc of contrast. And now I infuse 1 cc of imipenem mixture. How is the experience, Dr. Sam, Dr. Kim, Dr. Park?
Is those of the imipenem I used is the same with the Dr. Okuno, because I've learned the use of the imipenem from him. And usually in the food, usually the Achilles tendinopathy or the synovitis, usually feeding artery is too small. So the very small dose of the imipenem is enough to occlude the disappear of the brushing.
Yeah.
So the 1 or 2 milliliter of the imipenem mixture with the combined with the contrast media is enough.
Yeah. Yeah. ちょっとごめんね。今ね、造影剤が少しちょっと、だんだん取れるから大丈夫。はい。
And are any of the panelists using anything apart from imipenem? Or do you have any suggestions for those countries where they can't get access to imipenem, what can be used?
Yeah, I think the next pair or Kipsa or Lipiodol is the alternative. And we know that works well, that these 3 materials works well. So if you cannot use the imipenem, you can use such a 3 material.
So maybe I can add something. So for tendinopathies, for example, we use in the first line imipenem, and there are some patients which don't get so better. So, or if they have a recurrence, for example, we change our strategy, for example, to NextVF.
Okay, yeah, I agree. I agree that such a strategy. So first line imipenem, if you can use some first line imipenem, but we noticed in the recent JBIR paper, the tennis-elbow patellar tendinopathy, the next pair have better results. So knee OA is similar, but the tennis-elbow, the next pair was better. So our first line for tennis-elbow is the next pair. But the knee OA, the imipenem, next pair, and the Kipsa was similar results. So good results.
What about the shoulder? Dr. Okuno?
Shoulder, the Kipsa is good for shoulder.
Yes, I think so. Yeah.
Yeah, Kipsa is good for shoulder. Yeah, we noticed that. I'm not sure why, but next pair current size is not fit to the shoulder joint. I'm not sure
Yes,
why.
yes. The next spear is the spear.
Yes.
Yeah, and the hipja is the
It's a sponge.
particle. I think that difference can make some different result in shoulder.
Yes, I think so. So our first line for the shoulder is now also imipenem. Imipenem is first line for the shoulder. Today we don't have a shoulder case, but the next event we will do the shoulder. Sorry, I cannot. Maybe I cannot select this branch so quickly. Okay. So, Dr. Liang, what kind of embolic material you use? Usually imipenem?
Yeah. In Taiwan, we only have imipenem. Currently, we are not allowed to use Impisa or Nesvir.
Okay.
Yeah, so I only have experience with imipenem.
Okay. How is the Lipiodol? You didn't use Lipiodol?
We can use Lipiodol, but I personally don't have any experience with that.
Okay. I understand. Thank you. Maybe I can shower from here. It's so I think.
So I have a question. Did Dr. Okuno and the other commentators that I see a question from the audience that someone asked, do you try to use simplified TAME?
Yeah.
First before using the traditional methods.
Yeah, recently we are now doing lots of simplified embolization technique. That is a direct puncture to PTA or peroneal artery. Direct puncture to PTA or popliteal artery to treat Achilles tendinopathy. That works very well. Actually works very well. So and the patient's charge is very cheap. So we are now doing the lots of cases and now doing the comparative retrospective analysis of this material. Success is not. Okay. So I think this is not a primary point. So I will shower from this area. In this situation, so in many cases of Achilles tendon or plantar fascia, we cannot avoid to shower the material to the peripheral area. So that's why we have to use a temporary embolic. Now I'm giving the imipenem from the proximal point because I do not select the target artery like this. The target artery was very small and was not easy to select, so I have to shower from the proximal main trunk. But I think it's okay because this area is not a primary affected area. Okay, so I will go back to peroneal andごめんね、大丈夫。順調にいってますからね。もうちょいで終わるかな。I will go to the second round.
Yuji, there's a question from the audience. If you could specify the type of catheters again.
Oh, thank you. So microcatheter or the base catheter, angial catheter. Angial catheter is length is 65 and shape is Jadkin slide 2.5. So this one. This one. The length is 60. Length is 60, and the shape is like Jadkin slide 2.5, but the length is short. This is good for knee joint or the foot joint. And the microcatheter is 1.7. Single curve, Asahi microcatheter. Asahi Beruti microcatheter. Because the Achilles tendinopathy, we have to select the super select method is better results. So we want to select smoothly the target vessels, target small branch. So I think 1.7 is good. If you do the knee away GAE, we don't need the 1.7. 2.0 is enough. But for the Achilles tendinopathy, I recommend to use 1.7 to do the super selective, because the super selective is better results.
I totally agree, Yuji. But maybe just one comment.
Yes.
The microcatheter volute, which is available in at least Germany, are unfortunately too big in diameter, and they don't get through the mongoose catheter.
Really?
I tested it. So.
Okay. So that is so maybe yeah. So it's important such a thing is too. So if the microcatheter is fit to the angiocatheter or not is important.
Yeah, usually in the foot or the wrist, I think the operator needed to pick up the 1.7 or 1.6 French microcatheter to select the very small branch of the main artery.
Yes.
So the Dr. Katoh explained why you cannot use the small diameter of the microcatheter in Germany. But at least
I think it's a misunderstanding. Of course, we use a small microcatheter, but the volute, which is mentioned by Dr. Okuno, is in the proximal portion too big and doesn't fit through the 3.3 guiding catheter.
I understand. Now I'm coming back to the first target small branch and doing the super selective angio, and we can see the brush again. So that is natural usually. So now I'm doing the second round. So today I will do the second round by using imipenem and finish the procedure. The result is also good, but yeah. And now I want to deliver the imipenem by the arterial flow. So I'm inserting and pulling technique that is good for the deliver the imipenem, not strong. Okay, so I added the 0.5 cc of imipenem now. 大丈夫。今かゆいですか？いえ、大丈夫です。大丈夫。はい。Now patient doesn't feel anything now. The previous first round, he feels the itching, evokes pain, but now he doesn't feel anything. So that is a good thing. So I can confirm the reduction of pain receptor activity.
So you mean that we can expect the good result of
yes,
pain?
good.
Yeah.
Good result. 大丈夫ですか？はい。じゃあもう終わりますよ。はい。So now we can finish this procedure. So I confirm the reduction of evoked pain and yeah. So I think we can expect the good results from this procedure. Okay. So 終わりましょう。
Okay. Thank you very much,
great.
Yuji.
Yeah, I think we can review the.
So we'll let Dr. Yuji finish up the case and prepare the next case, but I think that's a very good result there.
But you can see at the very distal musculoskeletal vessel, it's very easy to spasm. Even you can see it on the after post-embolization. Even you use 1.7 French microcatheter, it's very easy to spasm. And if you use it on the wrist TFCC, the branch is very, very small. So I think just like Dr. Park said, you need very small one to approach wrist and the ankle and the foot.
Does anyone use intra-arterial lignocaine? Question from the audience.
No. I've not used it. Yeah.
No.
No, we're planning to actually.
I think that there has been obviously some data looking at intra-arterial lignocaine for use as an analgesic in some procedures. And there's mixed results. For example, in the uterine artery embolization space, it does provide some temporary relief of pain immediately, but actually once it wears off, the effect doesn't last very long because it washes away very quickly as compared to, say, subcutaneous lignocaine. So from my understanding, I'm not aware of anyone that's used intra-arterial lignocaine for MSK embolization. So, Marcus, do you know, is Nexosphere F, is that approved in Europe or is that approved in Germany?
Yeah, since last year. So we are able to use it since last year.
Oh, fantastic. And what size do you typically use for your TAME procedures?
What size do you mean by for the next
size particles? Yes.
particles? So we use an XF, so the fast degradable particles, which are in the size between 100 and 300 microns.
Yeah.
Is in Korea the 100 or to the 300 the next period or the Kipja is enough to make a good result in the elbow, wrist, foot, but sometimes in both shoulder and knee, sometimes we need to use the 300 to 500 next year or Kipja.
Okay, so now I will introduce briefly about the second case of tensor ball. It's okay, Gerard? It's okay. Okay. Yeah.
Thank you, Yuji.
All right. Thank you. Do you have any question for the first? I think we can review later. But if you have, okay. So, Dr. Liang. Okay.
Oh, I have a question regarding the shower technique you use in the previous case.
Yes.
Is that feasible for like a more like a next sphere because they have a longer degradation time?
Yes, yes. So if I use a next sphere or Kipsa, or I do not do such a shower technique. Yeah. So it's not good for infuse a large amount from the main trunk.
Okay.
Yeah.
So you need to super selective.
So I will take a
Okay,
time.
thank you.
If because his synovitis is not the main target, but if that was the main target, I will take a time and select and yeah. Okay, yeah, 行きましょうか. So okay, so now we can move to the next case, tensor ball. Can you see my slide? Okay, can you see? Okay.
Yes.
Yeah, thank you. So the 60 years old tensor ball patients, 10 months history of right lateral elbow, and he plays golf as a recreational level. It's just a hobby. And the pain NRS 7. Quick dash is a disability score of arm, shoulder, and hand. That is 22. 22 is not severe, not super severe, but mild to moderate. The next. And the physical exam was positive of Thomson test, and is a test for the extensor muscle pain induction. And the middle finger test positive, and tenderness over lateral epicondyle. And there was a hypoechoic area in ultrasound in ECRV and increased Doppler signal. And now you can see the MRI finding of STIR coronal elbow joint. You can see the yellow arrow shows the swelling of extensor tendon region. So we can diagnose the tensor elbow and we can expect hypervascularity in that region. And from our experience, the elbow is the only joint that is more prone to post-embolization pain. So elbow is weakest joint for ischemic event. So if you infuse too much, even though imipenem, if you infuse too much, it can induce can sometimes induce a strong pain for lasting 1 month. So that is the point of elbow joint. So we recently published a paper to JBIR comparing the 3 materials and the different area, and we found that the elbow joint is specific and very weak for the post-embolization pain. So aggressive embolization technique may lead worsen the clinical outcomes of TAME for tennis elbow. This is our recent paper, the title, and this is a figure of the JBIR recent paper. The left one showing the side effect of the post-embolization pain, the duration of increased pain after TAME, and the elbow joint, and each material can induce the longer pain. The longest one was 2 months, severe pain. But compared to other joints, the elbow joint is unique as a situation. So we strictly limit the total dose of embolic material. Even we use imipenem, the next pair or Kipser. The right one is the material-based frequency of increased pain. So from our experience, the Kipser for only in elbow, the Kipser can induce longer or higher frequency of pain side effect. Yeah, sometimes the imipenem also induce such a pain. Yes. And this is a figure from the JBIR paper. We compare the imipenem, and the middle one is Kipser, and the last one, lower, is NextPF. And the clinical success rate for tennis elbow was the better in the NextPF from our experience for lateral epicondylitis. But knee joint, as you can see, the knee joint, knee OA, the result was similar, very similar. So we think the knee OA, we can use everything, but for elbow, my recommendation is using NextPF, but this is our results, and maybe have some bias, or I'm not sure, but our results indicating that these things. But for the shoulder, the results was very nice. Okay, じゃあ次行きましょう。じゃあこれスキップして。So our planned procedure detail is radial access using 3 French sheaths and the 3 French angio catheter and the smaller curve, using smaller curve, and I will show you later, and the 1.7 microcatheter, and the target artery is radial recurrent artery, and sometimes interosseous recurrent, and sometimes brachial profunder is also communicating with radial recurrent, but we don't do the aggressive embolization. So we only treat the radial recurrent usually. And the embolic material we use in XPRF from now, and the technique is a very small amount injection, and the maximum total volume is 1.2 is our restriction. Do you have any question?
Yes, before we will approach not only radial recurrent and also from deep brachial artery and interosseous recurrent, and they give much amount, and in my cases they will tell me the post-embolization pain is very strong, and so, especially in young female, I'm not sure, in my experience. So we didn't routine to approach the deep brachial artery now, maybe just radial recurrent or sometimes also recurrent.
So previously we treat as many as possible. So we treat all the vessels, but now excludes the radial brachial profunder, deep brachial. But in the case, some patients, 10% patients have small radial recurrent. In that case, we will treat from the brachial profound.
Yeah, just like the patient we do in Taiwan. Yeah. Yeah.
Okay.
Okay, so we're going to let Dr. Yuji now prepare the patients. One of the questions which I can ask the panel, what or how do you mix imipenem? A very basic concept. I was wondering if one of the panel could answer that question.
So I can answer briefly if you want. It's very easy. You take 10 ml of contrast medium and put it into the bin of the antibiotic. And you can shake it, and I would say after a couple of minutes, you can use it. But remember, the degradation time is very short. We tend to prepare or make the preparation just immediately before the injection. So don't prepare it and put it on the table and then start with your intervention. I think this is not a good strategy.
Yeah, there are many articles show how to prepare the imipenem for embolization. The concentration is about 500 microgram in 10 cc contrast. And just like Dr. Katoh said, don't mix it too early because it will degrade very soon. Yeah.
I usually mix it in with a three-way stopcock, and every time before I inject, I will mix it again. So to make sure still mix it well.
As I use the same technique with you guys.
Now I'm giving the local anesthesia, superficial layer of radial artery, and not only the superficial and also the deep, the same area. It's important to reduce the procedure pain access. So now I'm giving the local anesthesia, not only superficial layer, but also the same layer of the radial. That is important. Okay. That's it. So, Dr. Katoh, which access you use when you treat the tensile bone?
I have to admit, I usually use femoral access.
Okay, good. Yeah.
Because I had some experience where we came from radial.
Yeah.
And so when we wanted to completely treat all the vessels, it was sometimes difficult to get access.
Okay,
with,
so bifurcation.
Reverse the angle.
So yeah, if you do 2 or 3 U-turns, it seemed to be sometimes difficult, and the path from above, so coming from proximal, seemed to be more natural. But I'm very curious to see how you do the elbow, Yuji.
Okay, I will show you. What procedure did you actually observe when you first come to Tokyo, Dr. Katoh?
I remember it was a lot of knees.
Okay.
But also a few cases of shoulder.
Shoulder and knee, okay. that makes sense, please.
And I think shoulder is perfect from radial. So I love to do it shoulder from radial, but yeah, had some bad experience with the elbow.
Yes, yes. Sometimes difficult is the bifurcation. So I explained.
Yuji, it looks like the 3 French Swiss.
Yes, yes. I use the 3 French, and this is the difference. This I'm gonna use this one. This one. ちょっと並べて、ここに横に並べて。違う、違う。ページを比べて。ごめんね。This was previous one. This was for shoulder or elbow. Sorry, shoulder or knee joint. This is for elbow. The relatively small curve compared to this one. Just show me that. I will use this one, small curve, smaller curve. Little bit difference, but this difference is sometimes big.
Okay, so the left one is the JR1 or?
Yeah, not the JR, it's similar to JR, but yeah, we order to make the smaller curve. So yeah, it's like JR type, like JR1. Yeah, like JR1.
What is how is the name of the configuration of the right?
Sorry.
What was the name of the configuration from the right catheter you showed?
Right catheter we call the musculo 2 MSK2, but it's a local name. So
okay.
Yeah.
Yeah, I think it's not available in Korea.
Sorry.
Usually I like to pick up the omniflush catheter. It makes the reverse curve, so I think it's not difficult to select the recurrent radial or recurrent oral artery.
Okay.
So as the Dr. Katoh mentioned, the femoral access is a good option to treat the elbow pain because the course doesn't have any the tortures or reverse the angle, but it makes the patient to stay longer than the radial access in the hospital.
Yeah.
So usually in my lab the elbow patient should discharge the several hours after right after the procedure. So I usually like to get in access through the radial artery and use the omniflush 5 French omniflush catheter. Omniflush catheter, it can make the reverse angle, so make it easy to select the recurrent artery of radial or ulna, but sometimes it's really difficult to give the torque of the microcatheter. So we should rotate the omniflush catheter itself.
Is it a 3F? Is it a 3F catheter?
Excuse me?
Is it a 3F catheter, the omniflush?
No, 5 French.
5 French through radial.
Yeah. 5 French is not, it doesn't make any problem.
Okay.
Yeah.
We love to stay small.
Oh yeah. The patient has if the patient has the less than 2 millimeter of radial artery, we need to avoid the radial artery.
Okay, now I'm prepared. Maybe I think you can see the rate. Can you see?
Yes, we can. Thank you.
Okay. So first I will take a whole joint angiography from brachial artery from here. So take a first angiography from the brachial. Okay, we can see the brush. Yeah.
Wow.
内側を見たいですか、肘の内側は。痛くないですね。はい。So, okay, so as you can, we can see this point is affected area. This one, as you can see. Yeah. And we can see that the primary target artery is radial recurrent. Radial recurrent have big branch to that area.
So, Yuji, what do you think of the lower lesion? Is the below the top of the artery and the small crossing.
So you mean the you talk about sorry what? Sorry, I could not hear that. The branch, the other branch.
Yes, below the top of the recurrent radial artery.
Okay.
The more proximal one.
Proximal, yeah. Proximal one is also maybe connect. But I think I don't do that.
You don't embolize that.
Yeah, I think I will skip. Maybe we can check later. But okay, so now you can see my under catheter is now reaching to the this one. This one is can you see? This one is radial recurrent. So I inserted. Now I'm inserting the microcatheter into this branch. So like this. Sometimes I use the torquability of this product. Okay, and here is okay. Here is good point. Okay, here is good point to do super selective angiography. Sorry, this is not good. Just a moment. This one is good. Okay. Okay, we can see the brush. And early venous range. Okay, so here is good point to start. So I will prepare the next pair from here. Next pair.
So a question for the panel. One of the audience members have asked, what other MSK territories can be embolized using a radial or brachial axis?
So for me, thank you for shoulder and elbow is a good from the radial access. Yeah, I think. And actually we do lots of case of neck, but I know it's not. We don't recommend. It's not easy. It's not easy. So the good to start is the shoulder and elbow, I think. How do you think, Dr. Liang? Dr. Liang or Dr. Bo? How do you think? Maybe the wrist is also a target from radial puncture, TFCC, or maybe. How do you think?
We do from the trapezius, shoulder, elbow, and TFCC as well. And if in case of like a radial site, like an OA or like a tendinopathies, sometimes I would use an ulnar approach.
You choose, sometimes you choose ulnar approach. Okay.
To go make a turn into super selective into the branches.
Okay, good. I understand.
Yeah, for wrist like decrepit disease or TFCC, I will choose brachial artery antegrade puncture, and we do about 50 to 60 cases. It's okay, but should be careful about the hemostasis, about the pseudo aneurysm formation, something like that. And I ask you that for the medial epicondylitis or for TFCC, if you approach, you let the patient flex his elbow to make the angle more smoothly, right? Because if you want to approach from radial artery to medial elbow or TFCC, you tell me that you will ask the patient to flex his or her elbow.
Okay.
Right?
Okay. Yeah. So yeah, that's it. I also experienced one patient using brachial artery and develop pseudo aneurysm. So I don't want to develop that. So I usually do not use brachial. Now I'm infusing 0.1 cc of Nexpir from here. So I think there are lots of patients of trapezius in Asian, East Asian, but how about in Europe or Australia? Do you have lots of patients of trapezius muscle pain or Dr. Katoh?
Actually, we don't have this word katakori.
Katakori is a Japanese word that means trapezius. Yeah, kata means shoulder.
Kata means shoulder. Yeah.
Yes.
Yeah. But
The
this was
kori
my
means
shoulder.
stiffness. Kori means stiffness.
Katakori.
Katakori is a very common symptom in Japan.
That's similar in Korea. But I have not tried the trapezius embolization.
Really? Okay.
Yeah. I just observed the several cases in your lab.
Okay.
Yeah, but not tried yet.
Okay. Yeah.
Same in Australia. Trapezius pain is reasonably common, but I've not tried embolizing trapezius pain.
I was in UK. No. And now we have one physician observation from UK. But he said no. Not common in UK. Not we know.
Seems to be an Asian thing.
Okay, so I put the 0.1 3 times. Now I can see the little bit stasis. So I will do the angiography again. Okay, so now the brush decreased. So I move to the other branch and come back here later. So I think the difficult part from radial access is go over the bifurcation of this bifurcation, this one. So from radial to ulnar, this bifurcation. And this angle becomes much easier if the patient bends the elbow joint. So I will ask him to bend. ちょっと曲げますよ。ごめんなさいね。大丈夫ですか? So I ask.
Hey, Yuji?
Yes?
If the patient, the tenderness is gone.
Yeah.
Now. Do you try to do the embolization more or stop?
Yeah. For the tennis elbow, we check the tenderness, but we don't focus on too much, because if we focus too much and if we want to confirm, and and it results to give the more amount of embolic material and sometimes make ischemic pain. So just angiography is okay, just angiography.
Yes, I think so. Yeah.
So now,
usually before in my lab, before I'm going to the other branch, usually I checked the tendonitis after the embolization.
Tenderness.
Once.
Okay.
Yeah.
Okay, good. Yes. So the later is okay. So we don't need to do that soon after the first embolization. So now I make the patient's elbow a little bit bending, and now we can see the. Sorry, just a moment. Okay, so now. So now the angle is getting milder. Sorry, this is. I think it's better to change the angle, but okay. So こっちの方がいいかな。ちょっと待って。こっちの方がいい。The lateral view. Okay, I changed to the lateral view. Okay. So as you can see, it's now elbow joint a little bit bending, and now the angle to the bifurcation becomes much easier. So we can insert the microcatheter to this cone. And this lateral view, it's much easier to identify the interosseous recurrent. This is interosseous recurrent. Let's go to the posterior side. And after that, I asked the patient to and make elbow the normal angle, extend the elbow, and then perform the angiography from interosseous. This is angiography of interosseous recurrent artery. So this is, we can say this is some brush of synovium tissue. Maybe we can give the small amount of neck sphere from here. This is a synovium tissue brush. So I will infuse the 0.1 or 0.2 from here, but not.
Do you think it could be related to the patient pain?
Sometimes related. So we check the tenderness, not only the lateral epicondyle, but also the posterior lateral synovium tissue. Yeah, some patients develop the synovitis in the posterior side. So in that case, we will treat the interosseous. But this case, he doesn't have a tenderness, so it's not primary lesion.
Yeah, good. That's good information.
Is it again VisiPuck, the contrast medium you use?
Yes, VisiPuck. Yeah.
Okay.
So patients usually, if we use a VisiPuck and if we use a neck sphere, it doesn't cause evoked pain.
Yeah.
If you want to gain the evoked pain, you can change to the higher osmolarity usual contrast.
Yeah, actually, that's what we do because I think it's helpful to have the information.
Yes.
At the correct location.
Yes.
So if we inject the contrast medium, and if we have the pain, and we can ask the patient where the pain is.
Yes.
And if this is the same location as they experience in daily routine or during sports,
yes.
I think it's kind of helpful, and the patient
I think
can specify it very accurately.
Yeah. So sometimes I ask my staff member to bring the small amount of usual contrast, higher osmolarity contrast, and to induce the evoked pain. That is very useful. I agree. Okay, so this is follow-up angio from the interosseous recurrent, and we can see the brush is reduced. So I will go back to the radial recurrent again. So I spending some time to selecting the other artery, and we can expect the recanalize or redistribute of the first embolic material. So now this is the second round. Yeah, we can see the brush again. Okay, so maybe we can add the next layer again. I will add the 0.2 from here. The total is 0.5 from the radial recurrent.
Now, are you using the 100 to 300 of next year?
Yes, 100 to 300. Yeah.
Why don't you put in the bigger one?
I think yeah, because I don't know. Actually, I'm not sure. Maybe the 3 to 500 is maybe good, but I've never tried it. Maybe yeah. How do you think so? What's the recent paper? Recent paper to JBIR describes that imipenem actually blocked blood vessel size diameter was 250. So I think around 250 is good, sometimes good, but I'm not sure. Okay, so.
But maybe just for my knowledge, the next sphere are they available also in bigger sizes? I mean, in Europe, not.
No, I have never tried. I don't have, but I think the Dr. Sam Park Sang-woo asked them to produce the bigger one, right? That's correct.
Yeah, it's I think the patient has some big extent of the brucey. Yeah. So I think the 300 to 500 the next peer could be helpful. The reduce the procedure time. Yeah.
Okay.
And just to clarify, so next sphere F is the one that's indicated for musculoskeletal embolization in several countries, which comes in 100 to 300, where I think Dr. Park's talking about the classic neck sphere, which is the general embolic agent, which comes in other sizes.
The next sphere F.
Next sphere F as well. Maybe it's Korea only.
Maybe Korea only, maybe.
Yeah. Because it made by the Korean company.
Yes.
Yeah.
We look forward to having it, hopefully one day.
Yeah, I think in Australia recently the next PF is available. Recently, I'm not sure, but some physician from Australia told me that they can use NextPair recently, NextPair F in Australia.
We have a way of getting around regulations only for special purposes. So it requires a little bit of paperwork to get items that are not fully registered yet. So we can use it.
Okay. So now I infuse 0.1 or several times, and total now 0.9 cc. And I will check the tenderness, but I don't focus too much about the disappearance of tenderness. あと、ごめんね。ありますよ。実は押しといたかったかなと思う。そうですね。これはどうですか、今。もうちょっと先端の方がそこはそうでもないです。この辺。はい。大丈夫。今は大丈夫。大丈夫です。はい。So now his tenderness is decreased. So I think we can finish the procedure.
ありますか？
ありません。
ありません。
今、there is no tenderness. arimasen. Okay.
Yuji, question: What is about the ulnar recurrent?
Okay.
After?
Yeah. So ulnar recurrent is sometimes important for the medial epicondylitis. Medial.
Yeah, but
Yeah.
sometimes it's a strong collateralization also to the lateral side.
Okay. So you mean the ulnar collateral. Okay. I understand. Yeah. That's right. Okay, I will check. Okay, just a moment. This is the ulnar collateral. As Katoh, Dr. Katoh mentioned, there is some small branch. This is actually ulnar side, but there is a small communication to the lateral, like this. Good. Can you see? I think you can see. Yeah. So we can see this communication, but I usually I do not embolize this area. But if the patient do not have lots of brush from here, yeah.
Okay.
So this case we cannot see the strong brush, so I will skip this article.
Okay.
Okay, thank you. But good point, very good. Yeah, some patients have a small radial recurrent, and some patients have a greater anastomosis from here, and sometimes we need to do that. Okay, but this time I will skip and finish the procedure. ありがとうございました。OK。じゃあ、ちょっとアナウンスに入る。ジェラード、ちょっとアナウンス入りました。
Okay, thank you very much, Yuji.
Thank you.
So great case there. And so now, while Yuji is preparing for the last case, we'd like to make an announcement. So could we have the slides, please? So while we're getting these slides up, so we'd like to announce the VENTI meeting, which is the first, in fact, it's the inaugural Congress for MSK embolization run by Dr. Okuno and I. And this is going to be run in Tokyo on November the 7th and November the 8th in 2025, later this year. This is a Congress that's going to focus on MSK embolization, but also other nerve interventions such as percutaneous injections, percutaneous ablations. There'll also be some talk about prostate artery embolization and cryoablation. So it's a very comprehensive course that's going to cover lots of different topics. And I'm pleased to announce that we're going to be joined by all of the commentators here on the live webinar case today. They're joining us in Tokyo. So the early bird registration ends on May the 1st. So please scan the QR code if you'd like to find out more about the conference, or if you Google search VENTI 2025, you'll be able to find the website, which will tell you more about the Congress. And we are opening up the scientific abstract and case report abstract submissions very soon. We'll be also pleased to announce that there is going to be some competitions where the best rated cases, as well as the best rated scientific abstracts, will receive prizes. And we can't tell you what the prizes are quite yet, but they're going to be quite generous. So I would encourage everyone to submit any particular case reports they have or any scientific research to the Congress. And further details will be available on the VENTI website shortly. And if you're enjoying this webinar, I would encourage you to join us for the next two webinars. We have two more scheduled on May the 3rd, which is a Saturday at 7 p.m. Japanese time, as well as on the 1st of June at 10 a.m. Japanese time. The first, or this, I should say the second live demonstrations is going to be a shoulder day, where we're going to be talking about shoulder embolization, such as frozen shoulder, etc., and synovitis. And the third live cases demonstration, which will be on the 1st of June, is going to be talking about geniculate artery embolization. So I would encourage you to join these. Again, please keep an eye on the VENTI website for registration details and further information about these upcoming live demonstrations. So thank you very much. So I might just, before we move on to the next case, ask the panelists some questions. So when you perform, Dr. Katoh, a question for you. And so you said that you tend to use femoral access when you perform medial epicondylitis and lateral epicondylitis embolizations. What sort of catheters do you use to get round to that distance?
For this purpose, we usually use an 4F catheter in a we call it vertebralis, so for the artery vertebralis shape. With this kind of catheter, we can get to the brachial artery, and from this distance, it's very easy to approach the smaller vessels from the elbow with a 1.7F catheter. So it should be at least 150 centimeters long, but I think this is a standard.
And so the vertebral catheter is at 120 centimeters long, or is that 150?
No, it's actually 100.
100, yes. And what about the rest of the panelists? Do you have a preference of going the radial approach or the femoral approach?
Yes, so as I mentioned before, I prefer the radial access in the when I treat the elbow or the shoulder or the TFCC, the wrist, other side of the wrist pain, and the DOA and the foot lesion, I prefer the femoral arterial access.
What about yourself, Dr. Wang or Dr. Keng?
Oh, I prefer radial access, and I usually use the Roche inferior mesenteric artery catheter for elbow, and it works in most of the cases.
I like to use brachial access for shoulder or for wrist because the shoulder we have only 65 centimeter J curve, and for suprascapular artery, for me the angel catheter 4 French is more easier for me to approach the suprascapular artery. So I use radial artery for elbow joint, but for wrist joint or for shoulder, I will use brachial approach. Yeah, but for knee, for ankle, for foot, I use transfemoral access. Yeah.
Yeah, I find that for MSK embolizations, generally the population is a little bit younger than what we would treat for peripheral vascular disease. So I find that we don't run into as many problems with accessing arteries or having heavily calcified arteries, except maybe for a few of the geniculate artery embolization patients who are a little bit older. So I think the access
Correct.
either way, even in the radial, is actually quite suitable for most of these procedures.
Yes.
A question from one of the audience members was that for uncomplicated cases where you use either transradial or transfemoral approaches, how long do you keep these patients post-procedure before you discharge them?
Take the question first. I usually use the 5 French or 4 French standard sheaths. I usually keep the patients around 2 hours after the procedure, and they usually leave and without any event.
Yeah, for transradial artery, we use full French, and after remove the sheath, I will use TR band and something compression, hemostasis, and I will let them stay for about 4 hours to keep compression. And for brachial, I will use sandbag to compress brachial. I didn't recommend brachial artery so much because I produced one shoot on any recent cases. Yeah, so maybe transradial is better. Maybe, yeah.
In radial access, I applied the pressure bandage in the radial artery, and patient usually the stay in the hospital 2 to 2.5 hours. In the femoral arteries, I use the closure device like port close or the Ming's closure device. So the patient should stay here for the 4 hours.
Okay. How about Marcus, Dr. Katoh?
Yeah, I have to admit that our patients stay for one night.
Okay.
But it's also an issue of reimbursement. So
reimbursement. Okay, I understand. Okay, it's important. It's important. Okay, so can I show you the last case information? Okay.
Yes, please go ahead, Yuji. Thank you.
That's the last case is knee away. So can you see my screen? Okay. So 70 years old female, 5 years history of knee pain, and both medial side and lateral side, but medial is severe, and sometimes she has swelling and effusion, and severe pain when going downstairs or standing up from a chair, and no pain during the level walking. During the level walking, no pain. It means that the bone marrow subchondral region is relatively healthy. So that is a good indication for GAE, because the patients who have a weak or severe condition of bone marrow, especially the subchondral bone marrow, that can develop the level walking pain, and it doesn't want, it sometimes do not, it's not good outcomes. But I think this is a good indication. And the pain in anterior medial knee during the turning over in bed. So she also have nighttime pain. This is an MRI example of this patient's right knee. We can see the synovitis in the lateral side, in the coronal tissue. What's that MRI? We can see the higher intensity in the lateral side, and the meniscus. There is no extrusion of lateral meniscus. And but usually we check the three things in a knee MRI. First is the presence of synovitis. So we can see the fusion and the thickness of synovium tissue. So we can say that these patients have synovitis. So these patients have brush. And the second thing, we want to exclude the meniscus, surgical indication meniscus region. But like a degenerative change or extrusion, we can ignore that. The degenerative horizontal tear, we can ignore that. But if the patients have mechanical pain, that was due to the mechanical impingement of the meniscus radial tear or the bucket handle tear, such a thing. We want to exclude these patients because the result is not so good. Let's see. This is MRI. Also, her MRI, we can see the fusion, we can see the synovitis, and we could not find the meniscus severe lesion. And the third thing, the one is the synovium, the presence of synovitis. The second is excluding the meniscus surgical indication meniscus tear. The third thing is bone marrow, especially the subchondral bone marrow lesion. If the patients have, I think the Asian population have weak bone marrow condition, so we will exclude such patients. But these patients do not have a severe bone marrow damage. So I think basically, I think this is a good indication for GAE. And this is a planned procedure detail. The ipsilateral using 3 French and 1.7 microcatheter and using imipenem or Nexpert. But if the patients have very severe brush, that is a very high flow, maybe we will add the Embosphere 300 to 500 to reduce the future blood flow or future blood pressure. But I'm not sure these patients have lots of brush or not. But recently we will test such a thing. So maybe only imipenem or maybe only the Nexpert or maybe only the temporal, sometimes weak for the large brush, high flow patients. So if the patients have high flow, we first infuse imipenem, and after that, in the second round, maybe we will add the Embosphere, permanent microsphere, a small, very small amount to reduce the future blood flow. But I'm not sure yet that it contributes the better results or not. But we recently testing such an idea, combined idea, that first imipenem and next, if the patients have high flow, maybe we can add the permanent microsphere. Of course, we can also treat by using only a permanent microsphere, like 100 embosim or 100 to 300 embosphere. But in our country, we prefer to use a temporary in our country. Okay, so let's do the procedure. If you have any question, please ask later. Okay,
Okay, thanks very much, Yuji. Another question for the panelists from the audience is, do you always perform an MRI with contrast before doing GAE, or can you do other imaging modalities?
Actually, I perform contrast MRI for every cases, including knee, and I also do MR angiography. And I can see the angiogenesis and see the map and which vessel supply the angiogenesis. I think, and I published the article and with Dr. Liang 2 or 3 months ago so maybe contrast MRI and plus contrast MR angiography will help, I think, but only for study purpose. I don't know other commentators' condition or the routine.
I usually performed an MRI for every cases. The purpose of that is mainly to exclude the patients like a bulky handle tear, meniscus body handle tear, or large loose bodies in the intra-articular that maybe have a surgical indication. And in my experience, those cases are do not respond well to the TAME procedure. So that's the main purpose of MRI. But contrast enhancement is not necessary. I think non-contrast MRI is good enough for the evaluation.
So I think so.
Is the TAME procedure is not reimbursed in Korea, so usually the patient with the pain will be planned to get the treatment of the TAME. Doesn't take the MR or contrast enhanced MR, but some patients enrolled in my research, the patient take the MRI. Is the contrast MRI? I don't think that it may not be necessary for the before going to the TAME procedure.
Okay, can you hear me? Okay, so
Yes, we can. Thank you.
thank you. So I have prepared Failure. So I will begin to use the full angiography from the commentary. Okay, so now I will start to use the computer watering angiography from the femoral sheath, from the sheath, by infusing 10 cc contrast. Okay. Okay. So we can say that the brush is, we can see the brush, but it's not too severe. It's not severe. Yeah. So if this, we can say that this, sorry, this time, this one. This sign is a descending genicular. We can see the descending genicular, and we also can see the inferior lateral. These two seems to be important, but of course we also check the inferior medial and the superior lateral too. Okay, so let's begin the procedure. Can you hear? Can you hear me? Okay.
Yes, we can. Thank you very much, Yuji.
Thanks. Thank you. So first, I will go to the descending genicular. So can you see our catheter?
Yes, we can see that very clearly.
Okay. Now I'm reaching to the descending genicular. It usually arises from the medial side. This is the superior patella, relatively large. But she has a lots of effusion. She has some effusion, so sometimes this superior patella is also important. So I will check. This is superior patella. This here is okay. Okay, so check the angiography from here. Superior patella. It's not a major one, but in the patients who have big effusion, this area is sometimes important. So I will explain this finding. So this area is a muscle brush. This is muscle brush. It's normal, but this area, the superior patellar region, this is a finding of synovitis. This is a finding of synovitis here. So maybe I can insert the microcatheter more, but this artery is very easy to become spasm. It's easy to spasm. So maybe I cannot go over. Yeah, sometimes it's difficult to insert this. Like this. So I think here is okay. Becoming spasm. Now becoming spasm. 痛い、大丈夫です。ちょっとつってるでしょ。So now the patients feels muscle strain or the spasm of muscle. So I will pass this and come back later. 大丈夫？はい。Then this is a descending genicular artery. So I skip the superior patella first, and we want to go to the descending genicular. A little bit too, just a moment. Okay, so the condition is a little bit too. There are two branches. The inner one is articular branch. This is articular branch. Okay, so you can see the articular branch. So I will use the angiography from here. Descending genicular articular branch. The other branch is a cutaneous branch, superficial branch or cutaneous branch. That usually doesn't relate to the condition. So okay, from here, we can see the brush is not so heavy. We can say that brush is not so heavy, but we can see the brush. Yeah, okay. So this area, the capsular brush, this area, intrapatellar fat brush. This is the bone marrow brush. Not so heavy, not so strong. Okay, so I will insert the microcatheter into the and measure very technically. Okay. So we want to select we want to go to the articular branch, right? So, right. Okay. So these patients have a large descending genicular. So in this case, we don't have to check the superior medial, because the superior medial, if the patients have small descending genicular, we have large superior medial. But if the patients have large descending genicular, they usually she has small superior medial, and that doesn't contain the brush. Okay, so
Yuji, could you tell us a little bit more about the wire you're choosing here?
Yeah, thank you. So this is Asahi Meister. ちょっと箱持ってきてもらおう。Asahi Meister。ちょっと箱持ってきてもらえる？ガイドワイヤーの。Asahi Meister and the small curve and 1/16. And
1/6.
Yes, 1/6. Okay.
Thank you. And I saw that you were also curving the end of the wire. Is that correct?
Yes, yes. Now I'm making a curve. Yeah. Yeah, because the thing, yeah. Thank you. I want to try to use the capsular branch. This descending genicular have two branch, cutaneous branch and articular branch. Now we are at articular branch. And the first two branch, the bone marrow branch and the capsular branch. The outside one is the capsular branch. I want to go to capsular branch. Just a moment. This is capsular branch. Okay.
I'm always impressed on how visible the Asahi wires are.
Yeah,
very easy to see.
It's easy to see for you?
Yeah, very easy to see.
Okay, okay. So now we can see the communication between between the from the descending genicular and the communication with to the anterior medial part of the knee joint, and communicate with the bone marrow branch or sorry, this is superior patellar branch. the communication, this area was superior patellar branch, this one. And this is a communication between the cutaneous branch, this one. This is cutaneous branch communication. This is a communication between the inferior lateral. The communication with inferior lateral. Actually, there are lots of communication. And from here, I will use the imipenem. Next pair or Chipsa is also good. I think Ripador is also good. And 0.5 cc from here. So ちょっと熱いかな今。今ね、お薬をね、内側の方に入れてますね。うん。
裏側の内側の筋が。
あ、そっかそっか。じゃあそこもやりますね。大丈夫今。今ちょっと熱いでしょ。熱い感じ痛い熱い。ちょっと痛い。うん。The patient now feels a box pain in the medial side.
For the audience members, it's important to realize that for those who've not performed TAME or musculoskeletal embolizations, that the angiographic endpoint really is what you're trying to achieve is the pruning of the vessels rather than a complete embolization of the vessel leading up to the particular joint.
Yeah, so for the GAE, using a permanent microsphere, the ideal endpoint is prune, not the complete stasis. But using the imipenem, we can do the complete stasis is okay. Yeah, so it depends on the material, which material you use. But temporarily, if you use a temporary embolic, the complete stasis is also okay, acceptable. Yeah. So now it's a follow-up angio. We can see the decrease of brush. How do you think? It's okay. Okay, so I also go to the bone marrow branch from here. This is the bone marrow branch. Okay. This patient doesn't have a bone marrow branch so much. So the very slight and brushes. But I think the Dr. Wang and Keng Wei Liang published a paper about the change of bone marrow lesion before and after GAE. How is the experience? Usually, the bone marrow lesion improved after GAE from your experience. Is that correct?
Yes, we always focus on synovitis about GAE, but after you review and search the article, you will also find that there are also angiogenesis within the bone marrow lesion. And
yes.
Yeah, lots of articles discuss about this. And after we do the pre and post GAE for bone marrow lesion, we found the amount decrease.
So you mean in that time you mean that bone marrow edema? That's right.
Bone marrow edema.
Yes. Yeah. So we can treat the bone marrow edema well by the GAE. Yeah, I think the bone marrow edema is still a good target. Good target.
Yeah, but for the cases with subchondral insufficiency, fracture or osteonecrosis, or we call sunk, it will also accompany with large bone marrow lesion or bone marrow edema, but the result of mine is not good. It's not the same.
Yeah, so we want to familiar the bone marrow lesion. If we say the bone marrow lesion, it includes the bone marrow edema, just edema. Edema is okay. It's very good patient. But SIFC or SONC is a necrotic or insufficient fracture. this is not a good indication.
Yeah, I
And
completely agree. Yeah.
yes, and the end stage knee OA have necrotic tissue and in the subchondral necrotic tissue. That is also a not good indication. Usually. How do you think of Dr. Katoh from your experience in Germany? Because we know that Asian population have a weaker bone marrow condition, but how do you think in Germany?
So I cannot talk about much about bone marrow edema.
Okay.
I have to admit, because we do not always do an MR. We don't have the capacity to do all
Okay.
this.
Yeah.
Most patients bring MRI from outside.
Yes.
But I have to admit that I think, of course, the more advanced arthrosis seems to have maybe decreased effects, or maybe not so long-lasting effects. But I think in the first line, we have to distinguish between arthrosis and arthritis.
Yes. Okay.
And my impression is, if we can help the patient to decrease the arthritis, they will.
Yes. あ、聞こえる？なんか悪くない。あ、あれ Can you hear me?
Yes, we can hear you.
Dr. Katoh, can you hear me?
Yeah, I can hear you.
Oh, okay. Thanks. So you mean that it's important to distinguish the osteoarthritis and
Yeah, I think it's two things. So arthrosis and arthritis are completely different types. This is my impression, and I had a lot of elderly patients. They had severe arthritis, and if you could treat this part, they get well.
Good. Okay. How do you think about the experience with Korean experience in your country, Dr. Park Song?
Yeah. Say that again, please.
How do you think about the bone marrow condition?
Yeah. Is the we can face the young patient with the bone marrow edema on MR without any some other reason in the joint. But I have not experience of the TAME procedure for the just bone marrow lesion.
Okay.
Yeah, but it could be. I think it could be good for reducing the pain in young patient with bone marrow edema.
Yes. Yeah, I think bone marrow edema we can manage by TAME procedure, GAE well. But it's sometimes not easy to take MRI in every patient in most countries. So that is a problem. Yeah, sometimes. But I think playing X-ray is also useful to see the bone marrow condition. Yeah, not so good.
Yeah, I think in those countries where MRI is not accessible, or perhaps patients can't afford MRIs, an X-ray and an ultrasound are very good alternative tests, because an ultrasound will be able to give you an idea of the synovial hypertrophy or the presence or absence of synovitis. It might not be able to exclude some of the meniscal disease, for example, or spontaneous necrosis of the knee. But at least it gives you a little bit more information.
Yeah. So now I'm infusing imipenem to the inferior lateral and relatively the it's aggressive, more aggressive compared to elbow joint. Please notice that if I do the same manner in the elbow joint, some patients will develop increase the pain, but knee away, usually it's okay. Okay, so next I will select the inferior medial. Inferior medial is arise from the anterior wall, usually anterior wall. I will so sometimes difficult or so. Let's go over.
So a question to the panel. One of the audience members has asked, does anyone use cone beam CT?
Okay, so how about Dr. Katoh? Do you?
I did it for, let's say, fun at the beginning, but I think it's not very useful, at least in my eyes. So if you get familiar with the vessels, and if you know that where you have to look for it, I would say it's not very helpful. And you also have to keep in mind, particularly in young patients, we have a laminar flow in this kind of vessels. And if you inject contrast medium, for example, through the sheath, you may not see all these vessels which goes out ventrally of the popliteal.
Yeah, it's important. So the contrast,
I'm not using it. I'm not using it.
So I found that inferior medial is very small in this case. So just a moment, I will show you. But yeah, I never try to use cone beam CT because I don't have that application. Yeah. Okay, so we can see the very small inferior medial. It's like this one. This one is inferior medial. Can you see my mouse? Okay.
Yes, we can see that. Thank you.
Yeah, this is it's very small inferior medial. So 60% cases, I don't use the microguide wire in the GAE, but sometimes, yeah, sometimes it's difficult. Yeah. So my usual method is to make direction by using angiocatheter and insert the microcatheter towards the target artery. And I think this artery is very challenging. Let's see, I cannot find this one. It's very small.
And about use of the cone beam CT, I know there is an article published by Dr. Padia about GAE. It can use to make sure the variation, the variant of the genicular artery, because there are a lot of variation in genicular artery and anatomy. So I saw he use CT, cone beam CT, or even now we have angio CT. We can use to make different classification, and maybe it will help us to do the procedure. Yeah, there are also doctor in Taiwan use cone beam CT to do in the GA procedure.
Okay, great. Use it for particles. Yeah, permanent particle. Yeah. So the Dr. Padia used a permanent particle, and in that case, maybe it's much useful or important to ところを難しいかもし
That is a very small artery, isn't it,
れない。
Yuji?
very small. Yeah. So, but sometimes doing the live demonstration, sometimes we have a very difficult situation in this moment. 大丈夫？うん。順調にいってますからね。OK です。So I think, okay, so now it's very tricky, but now I'm success to generate very tricky way, but yeah, this is inferior medial. Yeah, and also have small branch from the beginning of inferior medial is a popliteal side synovitis. Yeah, so we can see that this is a brush of unsetting bursitis. This is a brush of unsetting bursitis, and this is a brush of popliteal side soft tissue inflammation. So we can treat from here. But unsetting bursitis is very important pain source of knee away. Some patients have the common is a very common source of pain. So knee away is very heterogeneous. Some patients have bone marrow pain. Some patients have pes unsetting bursitis pain. Some patients have meniscus mechanical pain. Yeah, so we have to be more familiar about this pain source. It's very important. Now I'm treating the pes unsetting bursitis. で、膝裏も痛いんですよね。そう。And she also have popliteal pain. So popliteal side, posterior side pain. So I also check the median genicular artery. Yeah, that is arise in the common trunk with the superior lateral. Yeah, superior lateral. Okay, now I can see the stasis of the hemipaneum to the inferior medial. Okay. So now I will go to the superior lateral. Superior lateral. Here, the superior lateral usually arises from the anterior wall of popliteal artery in the in the level of upper wedge. Sorry, just a little bit difficult to understand. Yeah, this one. Okay, so I will perform the angiography from the origin of. Okay, so we can see the superior lateral, superior medial, small superior medial, and median genicular. And she has posterior side pain, popliteal pain. So I also want to treat the. Sorry, just a moment. So, 内側の筋、内側の後ろの方ね。OK、じゃあこれね、今から重要なところね。Okay, this is angiography of superior medial. We have brush, it's okay. And also the median genicular. Median genicular also has the brush. This is median genicular brush. The posterior side pain source, the posterior side. And this is the medial side capsular tissue. Okay. So here is a good point to treat.
So Yuji, usually the genicular medial artery supplies blood for the cruciate ligament.
Yes.
Any concerns?
Yeah, so if I infuse imipenem, we don't concern about that. But I don't use too much amount of next pair or permanent. Yeah, we should be careful using a permanent from here, because this is the only artery which can go inside the knee joint. Yeah. So that is important. So if the patients have popliteal pain, we have to treat the median genicular, but using a permanent is not so good for the popliteal pain. Yeah, because that is the only artery which can go inside the knee joint. So I recommend to use temporary or small amount. Yeah, not so much. Yeah.
Important point, yeah.
Yeah. Okay, so now I'm infuse enough amount of imipenem to the superior medial and the common trunk of superior medial and the median genicular. We can see the reduction of the brush here. It's okay. なんか熱かったです、さっき。
はい。
どこが熱かった？そこで。
痛くなる。
いつもね、後ろの方にね。
そうです。
So she has also a popliteal pain, and now she feels a box pain.
まさに。
まさにだね。
この
まさにそこです。And also the superior lateral is also very important for her. And use the red one. Do you have any comments or questions for the from audience or from panel? Okay.
There was a question which perhaps either the panel or Dr. Yuji can answer. So how necessary is it to use ice packs during GAE or any other TAME embolization?
Thanks. So I usually do not use the ice pack. And sometimes I use a permanent microsphere like 300 to 500, but that is not so inducing not cutaneous damage if I use a limited amount. So usually I do not use that. But some physician, for example, Anna from Spain, she used ice pack for the frozen shoulder embolization. I usually do not use that. How about the other panel?
So since I'm always working with temporal particles, I actually never use it.
Okay, never use. I think today.
Sometimes the ice pack is helpful after treatment of the plantar fasciitis. It's after the treatment of the plantar fasciitis, the patient have some burning sense in the plantar area of the foot. So the ice pack application could be helpful for reducing the pain or the burning sense.
Okay. Great.
And in our experience, the frozen shoulder case, if you give too much even imipenem in PCHA, the patient will feel deltoid muscle pain, post-embolization pain, or soreness. Sometimes you can use ice pack or even some glucose injection, intravascular injection will release the pain, post-embolization pain.
Really?
Yeah.
So now I'm infusing imipenem from the origin of these three arteries. So far, the patients have a strong evoked pain when the descending genicular and the superior medial and inferior lateral. So I will 大丈夫ですか？はい。Okay, so I think maybe we can do the second try, but I think single round is okay for the knee weight. So I will check the superior patellar because I skip it. これか。This one. Superior patellar. So I learned that for this, if I insert too much, the artery will spasm, make spasm. So I will shower from here. I will shower from here.これどっか痛くなります？ちょっとね、ピクピクって動くかもしれないです。はい。筋肉がね。うん。そこも普段痛い？うん。大丈夫です。全体に痛いんだよね。そうなんですね。うん。今はそんなに腫れてないですけど、腫れると思う。うん。裏側も腫れる。ああ、そうか。うん。腫れぼったくなっちゃうね。はい。Okay. Okay. So now I do the all of the target artery like superior patellar, descending genicular, superior medial, superior lateral, median genicular, inferior lateral, inferior medial. The 7. And she doesn't have. I will check the last one. Anterior lateral, anterior tibial recurrent. Okay. I will check the anterior tibial recurrent. I think that is not necessary for every patient, but I will check. First go to distal and get back. Not so big for the anterior recurrent. This is angiography from the anterior recurrent, including some brush. I think it's sometimes difficult to treat by using a permanent microsphere or choosing this anterior. These patients have 4 knee joint pain, so the number of treated artery is big. Like I checked every possible target artery, but usually we treat only the 3 or 4 artery. Sorry, this is very sometimes difficult.
Yeah, but this is really good for the audience to see the technique of looking at interrogating all the arteries.
Yeah, I think so. Yeah, I think so. Especially this part, sometimes very difficult. Now I'm inserting the microcatheter to the atria, anterior tibial recurrent artery. This is the final artery. And we can see the communication between the inferior lateral. This is the communication between inferior lateral. Okay, so I will infuse a small amount of mepenem from here and finish the procedure. Takes a long time. This artery is sometimes very important for treating the Osgood-Stadler disease, Osgood, or大丈夫？
はい。
今とか暑いです。
はい。
うん、どの辺？これ。うん。
うん。
これも普段痛い？
その辺がだから、
うん。
痛
いよね。
痛いのかわ
かんない。
裏がある。
うん。そうか、そうか。これ今ちょっとね、
はい。
やってますね。もう終わりますよ。ね。Okay, so I think we can finish this procedure. Okay, so we can see the more anastomosis compared to the previous. Okay, so that's it. We did the all 8 artery, select the all artery, and yeah, because the patients have 4 knee joint pain, inflammation, so we treated that all of the knee joint artery. Okay, so now we can see, we can finish this procedure.
So that's a great result, Yuji, and I think it's great to show the audience all the techniques of cannulating each of the individual branches. Great result.
Thank you. So I will go back to.
Okay, thank you. So while you wait for Dr. Okuno just to finish with that case, we've seen a great example of cases from Achilles tendinopathy, tennis elbow, knee osteoarthritis, just a handful of the different MSK embolization procedures that are possible. Do the panelists have any final thoughts while we're waiting for Dr. Okuno to join us?
Okay, thank you so much. Thank you so much. I
Yes.
think it was good. It was good to see the 3 lesion. Yeah, that's a little bit too long. Sorry.
No, I think that's fantastic. I think, it's great to see all the different procedures.
Mhm. Yeah.
It's an excellent procedure. Fantastic.
Thank you so much for being with us, taking time for this event. I appreciate having time until the late Saturday night, or yeah, I think the Gerard is I think your time is very deep, no?
Yes, it's a little bit late in Australia, but that's fine.
Thanks so much. And Dr. Katoh, thanks so much for having time, your daytime in your country. Thank you.
Okay. May I have a question?
Yeah.
To tendinopathy. So you distinguish between recreational sport level players and professionals.
Yes,
So
yes.
what is your thoughts about that? So why is it so different, and why can we help, or seems to be more difficult to help professional players?
It depends on the age, but usually the professional player means 20s or 30s or teenager, sometimes teenager. So these younger patients have good results, better results. So today I show the brief results of Achilles tendinopathy patients and competition patients, but still elderly patients like 40s or 50s. And usually 40s or 50s is difficult, more challenging compared to the younger athletic patients. So our recent published data for the patellar tendinopathy of 90 patients, and then we divided into the professional and college and high school and recreational. Recreational means 40s or 50s. And the result was the professional was the best, has the best results. So they have a good condition of, for example, the physical therapist, they have good physical therapist or trainers, and they are training manner is okay, is good, and the reconditioning recovery process is better, well organized recovery process. So the tendon disease, the recovery process is very important. We have to restrict the activity well and gradually increase the intensity of activity. So our results of patellar tendinopathy, the professional player have better results compared to high school student or recreational.
Okay, then I misunderstood you because I thought you say players which are under the competitional level that they do worse, but
yeah. So yeah, so the meaning of competitional is either 40s or 50s, but still do the competition.
okay.
Yeah. Sorry
But-
for the misunderstanding. Yeah.
Okay, yeah.
Yeah.
Because our impression is, particularly in younger patients,
Yeah.
that we do have to repeat the intervention maybe more times, so twice or
Oh, really? Okay.
in a more shorter interval compared to elderly patients.
Okay. Really. Yeah. So sorry for confused, but today's data of Achilles tendinopathy competition level is at the 40s or 50s, but still do the competition. This is sometimes challenging.
If you're treating, for example, professionals, when do you think about to do a redo if they are not satisfied?
Yeah, we usually announce the patients that we will do the 2 times for the tendinopathy tissue, or the tendinopathy disease, like patellar tendinopathy, Achilles tendinopathy. We announce that we will do the 2nd time. But some patients enough for the single treatment, but some patients needs a 2nd treatment. So we broadly announce that we will do this, we might do the 2nd treatment. So please.
After which period?
I think so. Sometimes very 1.5 months or 2 months or 3 months.
Yeah. Okay. Similar.
Yeah. Thank you. Yeah. So the managing the patients of activity level is important.
Okay, so we should probably wrap up, Yuji. We've run a little bit over, but I want to thank all the audience for staying with us.
Yes.
Yuji, any final thoughts?
Yes, thank you. So this time, this is our first time to do such a thing, and I think I can show some technique about the MSK embolization, and it's also good for the for these excellent worldwide experts comment, and this we can discuss deeper discuss about each branch or technique or the follow-up. So that was fantastic. Thank you so much. Thank you all of your comment, and thank you for your participants. Thank you.
Okay, so well, thank you very much, Yuji, and thank you very much to the expert panel. You've been fantastic in providing an excellent insight into the wonderful procedures that Yuji's done. So for the audience, we thank you for your participation. The recording will be made available after this, and so please keep an eye on your email so you'll be contacted by the VENTI staff with regards to the recording. And I would encourage you, please, if you can, for the attendees, please do fill out the survey that will appear on your screen shortly. Your feedback's important so that we can help to improve these webinars and provide relevant content to you. Okay. Thank you very much, everyone, and have a good evening or have a good day if you're on the other side of the world.
Yes.
Okay, thank you.
Have a good night. Thank you.
お疲れ様でした。
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 お疲れ様でした。ありがとうございました。
Okay, bye.
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 Thank you.